half past midnight, so it is a great time to talk about lipids. During this short talks, I would like to bring you and present you the most recent data, especially from our group, because we would like to we usually present the very practical issues and researchers, but during these talks, I would like to also to invite many different experts that and discuss with them the most debatable issues, for example, concerning the CAC score and power of zero, concerning lipoprotein little I, homozygous FH, rare diseases, and many other different issues that may cause problems in everyday clinical practice. But today I would like to say a few words about our recent paper that we presented within the International Lipid Expert Panel Steering Committee on the radius rise. Why it's important, I would like to share with you my screen with this paper, which is already published. As you can see, it is available in Science Direct in the journal with the impact factor over 10 pharmacological research. And here within this recognized group of experts, we decided to prepare a paper, the first recommendation ever on radius rise, which will be a kind of response to ESC prevention guidelines 2021, in which, as you may know, that the experts decided to did not recommend, in fact, radius rise, and they and it is probably based on the 2018 EFSA recommendation, but it is on the other hand is completely against the evidence-based medicine, because even in 2018 in August, EFSA made its recommendation based on the 30 cases from few authors on radius rise, especially which was contaminated with citrulline, and that is why they in the end they concluded that there is no safety dose of radius rise, which was a great surprise for all those experts and people that take care of nutraceuticals, and because radius rise is one of the best evidenced nutraceutical in the world, with omega-3 acid and phytosterols probably, but also with berberine, bergamot. And starting in 2018, after this decision, we prepared many different papers, research, meta-analysis in order to confirm that this decision was simply wrong. But on the other hand, this decision was quite also had some positive aspects, because we started to loudly talk about nutravigilancy, so about the safety of nutraceuticals, because it is, despite the fact these are natural products, but on the other hand, you know it very well that we always should talk about safety when we supplement, when we have a pharmacological agent, because safety is the most important, even more important than to efficacy. And there is no problem with the efficacy of a radius rise, even at low dose of monocolin K, because now the recommended dose with the decision at the beginning of, which was at the beginning of July, is less than 3 milligrams of monocolin K. But please remember that radius rise is not only monocolin K, but it is also other monocolins. These are also sterol stanols, omega-3 acids, and many other different components that is included in radius rise. And radius rise is usually in the combination with other nutraceuticals. For example, in one of the preparation, well-recognized armolipid with polycosanol, with berberine, with coenzyme Q10. So, and altogether, such combinations might indeed, which might be very effective with the reduction of LDL cholesterol, even by 20–25%. But here, this document was indeed a clear response for ASC, European Society of Cardiology Prevention Guidelines, which was from many points, which I consider as very good from many points, especially taking into account the score P introduction and replace of total cholesterol with non-HDL cholesterol. But there are so many different mistakes which are completely against evidence-based medicine that I'm totally surprised with this document, because it made a lot of chaos concerning, for example, stepwise approach to LDL cholesterol attainment for very high-risk patients and diabetic patients. It is also associated with alcohol consumption, which is still allowed despite the beautiful paper published by Global Burden of Disease, and only 3 risk groups and combination of low to and moderate risk group. And for all those patients, there's one LDL cholesterol level below 100. But let's focus a little bit on this paper. Within the group of experts, we say, okay, let's try to figure out what patients might benefit the most and what we should do in order to be very safe with radius rise preparation for those patients. So we evaluated all the available data since 2018 and previous obviously one, but especially in the newest one, in which we also in our groups were also very active within this period of time. And we, as you can see, we discussed many different issues, not only efficacy, because as I said, efficacy is quite obvious, and it was confirmed in hundreds of papers, hundreds in randomized controlled trials. Obviously, someone may say that these trials were usually small, take into account the number of patients. These trials were relatively low, short follow-up, but please remember that the main outcomes in those trials were reduction of the LDL cholesterol, total cholesterol, and the influence on the other lipoproteins. So that is all. We do not need very long trials. On the other hand, the radius rise has also outcome data. You probably remember one of these data in patients at very high risk patients that clearly showed the link with the reduction of the cardiovascular outcomes with the radius rise. But on the other hand, please remember that we know it very well that each reduction by 1 millimole per liter of LDL cholesterol is associated with about 20-22% reduction of cardiovascular outcomes. So that is why we in fact do not need any cardiovascular outcomes for radius rise and nutraceuticals. As you can see, we discussed a lot about the safety and nutri-vigilance. And as you can see, we many times trying to emphasize the role of contaminants. That way, we should be very careful with the preparation and quality of preparation we usually use and would like to suggest to our patients concerning the supplementation, because we only should use those preparations which are from well-recognized manufacturers and well-recognized pharmacological companies, because then we are almost sure that this was a great quality production. Now, on the other hand, it is without any contamination that may cause adverse effects. But altogether, please remember our meta-analysis that was published in 2018, as far as I remember, or just after the EFSA scientific opinion paper, in which we, together with Arrigo Cicero, with Federica Fogazzi and a few other members of our team, we clearly showed that based on the almost 6,000 patients, we noticed that there is no adverse effects related to radius rise. What is more, we also noticed based on the data from real-world data from Italy, when we observed the patients, consecutive patients that were treated with radius rise preparation, it was amolipid, and it was 2.3 million people, that the prevalence of adverse events is 0.03. So it is less than 1%, is less than 1 per mile. So that is why in real life data, there is almost no adverse effects associated with radius rise. It's a very safe nutraceutical, and we should remember about it. What is more, and here you have the results from the study we published in Archives of Medical Science. That is why if you look at the guidelines, as I said, there is a problem, because in 2019 guidelines, CAS guidelines, the same authors, François and others, said, okay, radius rise is the strongest evidence nutraceutical, and 2 years later, less than 2 years later, because it was 1 year and 9 months, they said, do not use radius rise. So that is why it is quite surprising for all of us. And that is why we wanted within this paper to say, okay, let's figure out what patients might benefit the most. And please have a look at this. First of all, if we would like to focus on patients that are not indicated for statin therapy owing to low cardiovascular risk. It is a great problem usually with those patients, because without indications and with still high level of LDL cholesterol, we should first start with non-pharmacological approach. With diet, with regular exercises, with loss of weight, and so on. So, but altogether, only about 20% of those patients, of our patients, are adherent. So, still after 3 to 6 months, we should consider nutraceutical or low-dose statin, and that is why for those patients we recommended that radius rise should be considered for patients who have a suboptimal lipid profile despite diet and lifestyle interventions, in those patients who are not still indicated for statin therapy. Another group of patients which are critically important is patients unwilling to take a statin. Unfortunately, there are so many patients we have in everyday clinical practice that are unwilling to use statins. They say, "Doctor, please, I would like to reduce my LDL cholesterol, but I don't want to use statin because I read it is associated with liver injury, with kidney injury, with hair loss, and so on. I don't want to talk now about the statin intolerance, but please remember that this is another very important issue to remember, that about even 7 to 10% of our patients are those that are unwilling, cannot agree, that would like to, cannot agree to use statins. We should convince them. We should say that statin may prolong their lives, but altogether, in the end, if they really don't want to use statin, we should try to find alternative. If these are patients with low to moderate risk, or especially with low risk, we should obviously go for nutraceuticals. And please have a look, if we look for this table, patients that are unwilling to take statins, in primary prevention, patients who, after careful education as to benefits and the risk of statin therapy, are unwilling to take statin, radius is recommended alone or in combination with other lipid-lowering therapies, for example, with ezetimibe, with bempedoic acid, and especially in primary prevention patients who, after careful education as to benefits of risk of lipid-lowering, are unwilling to take any lipid-lowering drugs, radius rise should be recommended. So these are very rare situations that patients do not agree to use ezetimibe, because ezetimibe is very safe, but it may happen. Another group of patients, these are obviously patients with statin intolerance and nocebo-placebo effect. You probably remember that we have just published a recommendation, first in the world recommendation of nocebo-placebo effect management, but these are indeed a group of patients. And in those patients who are unwilling to use statins, who are with statin intolerance, confirmed statin intolerance, it is only 9.1% based on our meta-analysis, or with nocebo-placebo effect, we should consider radius rise. So radius rise should be considered as an alternative approach to statin in patients with confirmed statin intolerance. Radius rise, obviously, in those patients that are at low to high risk, because in those at very high risk, we should always consider PCSK9 inhibitors and inclisiran. Radius rise may be considered as a part of supportive strategy to manage these lipidemias and cardiovascular risk in patients with statin-associated muscle more likely to result from the nocebo-placebo effect. And that is all. I believe it is still very high, very large population, low-risk patients, those who are unwilling to use statins, and those with statin intolerance or nocebo-placebo effect. So altogether, I believe it is most of our patients in primary prevention. I believe it is even 70% primary prevention patients that may benefit from radius rise. We do not recommend using radius rise secondary prevention, because I cannot imagine that in patients after acute coronary syndrome we should consider radius rise. We should do our best in order to be effective with intensive statin therapy, with combination therapy with ezetimibe, and with novel therapies with PCSK9 targeted approach. There are some contraindications which are quite similar to, obviously, to statins, and we should always, my apologies, remember about it. We should also remember about the recommendation on the required criteria for radius rise products, such as the radius rise products should be manufactured according to the principles of GMP, and with the daily dose below 3, based on the scientific opinion. Recommended minimum dose of citrulline, the less the better. It would be better. It would be the best to have any do not have any contamination, and fixed combination of natural products are obviously recommended. We should always discuss this issue with patients, and we always and try to educate our patients because all those issues here mentioned in the paper should be discussed with patients. So composition of Reddy's preparation, some patients should be informed that these are monocolin K, which is natural lovastatin, relative evidence base of efficacy and safety, duration of therapy, approximate cost of therapy because it is much more expensive than that low dose statins, and quality of products. I hope you understand how important it is to have our patients on LDL cholesterol goal. The lower the better, the earlier the better, the longer the better. So Reddy's rice might be one of the alternatives as a part of the non-pharmacological approach, as a part of the supplementation that might be helpful and supportive for those patients at low to moderate risk, those with unwilling to use statins, those with statin intolerance, nocebo effects. So as only you have any questions, please go ahead. And the next my Nighty talk about Lipids will be about statin intolerance. Thank you so much.